And there we go. And thanks everybody for coming today. This is our April version of the Health Innovation Team meeting. We meet on a monthly basis to discuss innovation, and particularly in the Kansas City area, and also taking on some national topics every now and then as well. Um, our plan today has been to have two presentations, unfortunately not exactly linked together, but still very innovative things happening in the Kansas City area in digital health. And so we wanted to expose those to you. The first presentation that we'll look at today is from NavMD, and Joe Bush, you're the strategic officer, Joe, is that right?
Close. Yeah, the Chief Strategy Officer, John.
Chief Strategy Officer. So there we go. And then we'll also hopefully hear from Kendra Wyatt on a national initiative that KC Digital Drive, um, Digital Health KC, and BioNexus are getting behind to try to advance a program here, a national program here in Kansas City. Um, but first, let's kind of go around the table and see who's here. If you just want to uh, give your name and your organization, that would be great. I will uh, go ahead. I'll start off. I'm John Fitzpatrick from KC Digital Drive. I organize these meetings typically on a monthly basis. Also, a number of projects in the community related to digital health. Jeff Vanderhagen, would you want to say hi?
Yeah, hello, Kansas City community. I'm here for business development opportunities, basically to network for digital health, and I'm excited to go to the Digital Health 201 event this evening at Polsinelli.
Great. Josh?
Hey there, everyone. Apologies for being off screen. Getting over a cold here, but Josh Weimer, Chief Health Information Data Strategy, Missouri Department of Health and Senior Services. Very excited to see today's presentations.
Joe. Joe Bush.
Yep, that was me. Sorry. Yeah, good morning, everybody. And again, John, thanks for the invite. Joe Bush, I'm the Chief Strategy Officer for NavMD, located here in good old Overland Park.
All right. I'm in Joe.
Hello, everyone. I'm not sure if you can hear me well. I am still on my way into work, which is why I am not on camera. So I am listening in on behalf of Dr. Alex Francisco. We are from the Kansas City Health Department. He is double booked as usual, so I am sitting in for him, and I am his note taker. I'm just not AI.
Probably better that way. Thanks so much, Aminju. Scott.
Who'd you say?
Oh,
Scott.
oh, yep. Sorry. Hey,
Yeah.
Scott, can you hear me okay?
Yes,
Sorry,
you're
I'm in
fine.
trance right now.
Okay.
Yep, Scott. Okay, yep, Scott Schiffelbein. I'm a M&A or deals partner based here in Kansas City with PricewaterhouseCoopers or PwC that focuses in the healthcare industry more broadly, payer provider, med tech, pharma life sciences, and health tech as well.
Great. Thank you. Amy.
Hi, everybody. I'm Amy Roberts. I'm also with the Kansas City, Missouri Health Department, and I'm with the Environmental Division.
Great. Stan.
I'm Stan Udlich. I am a semi-retired pharmacoepidemiologist interested in genomics right now, involved in both universities with adjunct appointments.
Great. Glenn.
Hi, I'm Glenn Fisher, CEO of NavMD. I have the pleasure to work with Joe Bush and on our mission to partner with the most forward-thinking companies in America to transform employee benefits one plan at a time.
Great. Dr. Weaver.
Morning. I'm Marcia Weaver. I'm the Chief Population Health Officer for St. Luke's BJC West Region and also a family medicine physician here in Kansas City. Nice to meet you.
Great. Thanks for coming. Jim.
Jim Starsov with KC Digital Drive. I will follow up with Jeff. You mentioned the Healthcare 201 tonight. So there is a Healthcare 201. I'm moderating a panel on using AI tools to develop a digital health MVP. It's 4 to 6 at Postinelli tonight, and you can sign up at the Digital Health KC.
Great. Thanks, Jim. Deb.
Morning, everybody. I'm Deb Cisco. You can find me in the quality department at University Health, and I lead all projects related to patient advocacy and engagement.
Great. Doug.
I'm Doug Hohulin. I'm on the chair of the humanities chair for the Kansas City Digital AI Club. And one of the focuses on AI in healthcare, and we're planning on having an event in August, September timeframe. And we look at AI in healthcare, AI in workforce development, education. So we had an event yesterday and have events once a month.
Great. Thanks, Doug. Ben.
Hello, everyone. My name is Ben Birnbaum, and I'm from Technology Venture Studios within UMKC. Two things bring me to the conversation today. First is I support 20 different regional institutions in commercializing their innovations through raising awareness. And then the other part of my job is to find digital health startups and supporting them in their launch through grant funding.
Great. Thanks, Ben. John.
I'm John Travis, spent many years at Cerner, and the last couple have my own consultancy working mainly with health IT companies, both in the Kansas City area and in the industry.
Thanks, John. Kinley. Kinley, would you like to say hello?
Hi, this is Kinley. I'm a community health worker and I'm with the Community Health Council. I'm here to learn the digital thing.
Very good. Thanks. Julie.
Hi, I'm running this morning, so
Sorry.
I'll spare you the picture. But I'm Julie Dusel-Culbertson. I'm a social entrepreneur in the health and wellness space. I presented about my nonprofit that educates adults about youth mental health a couple of months ago, and I'm excited to be here. Thanks for having me.
Great. Sage.
Hi there, my name is Sage Brown, and I'm a Director of Operations at KU Med. First time attending, pleasure to be here.
Great, thanks for coming. Let me see. Hamid. Hamid, are you with us? Okay. Hamid, just to kind of introduce her, all is kind of a major coordinator within Mid-America Regional Council. She has a particular background looking after operations for community health workers. Lucia.
Good morning, everyone. My name is Lucia. I am the Associate Director for Social Determinants of Health and Maternal Strategies at United Healthcare, one of the Medicaid plans in the state of Kansas.
Great, thank you. Let's see, who else do we have with us today? Meredith.
Hi, good morning. My name is Meredith Cantrell. I'm the program manager for community health initiatives at St. Luke's BJC West, and I do a lot of work on programs for our patients who have food, housing, and transportation insecurities that create barriers to accessing healthcare.
Great, welcome. Kevin.
Kevin Mills, I'm the president and CEO of BioKansas, which is now being relaunched as Ad Astra Bio. We are the state trade association for the life sciences and the state affiliate of the National Bio Organization.
Oh, thanks, Kevin. When does the new name become effective, or is it already?
It has become effective. We've sort of had a kind of semi-soft launch, but you'll see more announcements about the new name. And actually, we will now exist as two separate organizations. Ad Astra will be the trade association. BioKansas will continue to exist and support education and outreach mission.
Okay, great. Maybe we'll have you come describe that for us in one of these sessions.
Yeah, that'd be great. We'd love to.
Okay, great. Terry.
Hey, good morning, everyone. Terry Wimbush here. I'm with the Kansas City Health Department. I work with the Division of Community and Family Health Education.
Great. Kendra.
Hi, everybody. I'm Kendra. I'm Director of Programs and Education at BioKansas, and as Kevin mentioned, at Astra Bio. So I work with him.
Sounds great. Thank you. Liz.
Hey everybody, this is Liz Schaefer. I'm with Digital Health KC, and thanks for having us today, John. And I'm sure you're going to do a plug, but Healthcare 201, and I see Jim on here. Jim is our moderator, so I hope that I'll see a lot of people in person this afternoon.
Yeah, that would be great. Okay, is there anybody that I have missed? Okay. With that, let me pitch it over to Joe Bush. We are very eager to hear about NavMD. We have not usually heard anything from the benefits side of the health cycle, and so we are very eager to hear what Joe has to say. Go ahead, please, Joe.
Thanks again, John. I'm going to pull up a couple of slides here just to help facilitate the conversation a little bit. Can you guys see that okay?
It looks good.
Okay, awesome. And again, I'm incredibly grateful, John, that you reached out and invited us here this morning, but also giddy a little bit as well, because just going through those intros and those bios, there's no shortage of about half a dozen or so former Cerner associates listed on this call. So it's always great to kind of reconnect with many of you. And so just by way of introductions, and I know it was in the bio of the registration screen, my name is Joe Bush. I dutifully wear the title of Chief Strategy Officer for NavMD, which I like to describe as nothing more than a fancy title of I wear a bunch of different hats. I get to work with great people like Glenn Fisher, our CEO, on here, along with about 20 or so other associates at NavMD. So who is NavMD? I often describe our firm as really the non-startup startup. So we've been in business, really running behind the scenes since 2005. Started in Nashville, and then Glenn acquired the firm, moved it to Kansas City about 2019, 2020. And our mission is fairly simple: to improve the healthcare delivery for employer plans, really just one plan at a time. We often get asked, is NavMD a navigation company or a care coordination company? Not really. In fact, not at all. But we are a data and data analytics firm. Why do we have the term navigation in the name? Is really because it all starts with data. And as our mission is really around improving the healthcare one plan at a time, our core focus is on those 172 million Americans that get their healthcare through their employer plan. So if you are working for an employer, which many of you are, or maybe you're on the individual market here, we would love to talk. We would love to talk. But just to kind of get into a little bit about who we are, what we do, how we do it, I think it's always important to kind of start with what's the problem, right? So when we look at the problem of healthcare, and many of you are various flavors of this particular set of graphs, but in essence, the problem that we have with the U.S. healthcare system today, it's big. And that big problem is truly just around dollars and cents. Many of you have seen various flavors of this particular set of slides, graphs, and just call attention to the two that I have displayed here. While they're very, very similar, they're also very different in what they describe. So if we look at the slide on, or the visual on the left, it's really showing the growth in family insurance premiums for a family of four since 1999 to current present day state. A family of four insurance premiums are now north of $25,000 a year. And you can see by the orange bar is the proportion that is made up by worker contributions. And so that delta that between the orange and the blue is funds that those employers across the country are having to bear. Then when you look at just the total cost of care within the US across all payer segments, we are now approaching $5 trillion in healthcare. We all know, we all agree, healthcare is not sustainable in its current market. And so our mission is really to start to identify what happened within that particular plan and using data to drive that so that then we can figure out why and how we can actually go solve some of those complex challenges. Okay. So let's talk a little bit about NavMD and the firm and the work that we do. Just as that problem is very large as it pertains to the total cost of care, we also recognize that there's an increasing growing demand and pressures that are being placed on multiple markets. In the two markets that we primarily serve at are the broker/advisor or health plan TPA market, and then those employers, the employers directly. So what are some of those pressures that are being faced? Well, when we look at the broker and advisor segment that is representing the employers across the country, there is a rapid consolidation that is occurring across those different organizations. They have identified the fastest way for them to grow revenue is to consolidate and go buy competition. Why is that important in data and data analytics? Is they're constantly needing to look for differentiators to help grow that business. The second piece around the market pressures for a broker and advisor is they are being asked to go do more and more by their employers than they ever have been. I have a number of friends that are current and former insurance brokers, and the old adage of they spend half their time on the golf course and the other half trying to figure out how to go grow the business. We're focused on how can we help that broker and advisor differentiate themselves so that they can actually go win more business, but ultimately reduce the total cost of care for their plans. And the third piece that's really important that's creating that extra pressure on brokers and advisors and consultants is the growing level of scrutiny that is being placed on them to report out to what types of fees that they are taking from their insurance plans and the employers themselves. So with that increase in scrutiny, they need data, they need insights to be able to go track and perform against their requirements. And then the second market that we serve day in, day out are the employers themselves. This is really our fastest growing segment that we support, primarily driven by these core market pressures. One is employers now more than ever before, driven by legislation that's come out of Washington, that they have to be a good fiduciary of their health plan. Many of you may be familiar with some of the lawsuits that occurred in the 2007, 8, 9 around employers not being a good management of their 401k or retirement plans. That drove a lot of change in the investment or 401k market. That same level of activity and scrutiny is now being applied to health plans. Many of my former Cerner colleagues are very familiar with the meaningful use era that really drove providers across the nation to start using digital technologies, and they had to identify and show that they were using those in a meaningful manner. This is the meaningful use mode for data analytics in employer-sponsored care, because you have to have it. The other aspects that now employers are having to compete for better talent. And in order to have better talent and employees, they need to have great insurance programs and benefits to keep that talent coming through the front door. So that's a little bit about who we serve, employers and brokers and advisors, and a little bit about what's kind of driving our market. So what is it that we provide? At its core, we are data analytics for employers and their stakeholders. So we aggregate data from a variety of different sources, and then we have a team of engineers, BI developers that then create the analytical content that's going to help plans and their partners identify what happened within their plan across various health segmentation and cost insights, and identify why it happened. Being able to drill down, if you saw that spike in utilization or spike in pharmaceutical spend in the month of May, you want to know what drove that spend. Was it a particular prescription? Was it a particular set of new drugs entering the market? And then once you know why it happens, then using predictive analytics that we've built to be able to forecast what is the predicted cost and predicted utilization for that particular group in the next 12, 18, 24 months. So know what happened, why it happened, and being able to predict what is going to happen. So then activities can be put in place to go rein in utilization, rein in cost, again, for that plan sponsor, the employer, to be a good fiduciary of their healthcare dollars. So how do we do that? This is really the, I won't call it the secret sauce, but this is really where the rubber meets the road. So we, at our core, are all about the data and getting it directly from the data source. So majority of our data that we onboard into our ecosystem is all in structured data formats. So this is coming straight from third-party administrators, health plans, EHR, wellness programs, organizations that have defined layouts. And even though we still have a long way to go to have a standardization in medical claim extracts for data sources, we will aggregate and connect into those data sources and receive generally those feeds on a monthly basis. But then we are seeing a growing trend in the unstructured data. So think about all the other data types that an organization would want to go track that influence healthcare. So there was a few folks on the call here in their intros that talked about SDOH, or social determinants of health, or non-clinical, non-financial data points. We are very interested in aggregating those types of data and also understanding what are the right structures for them to come in. Once we get the data, then we go through a series of exercises that clean up the data. We'll call it the deduping, and making sure that Joe and Joseph Bush are all the same guy. But then applying intelligence on that raw data, because just getting a data feed that shows a CPT of 99213 for our audience doesn't make sense. They want to know, hey, how many office visits and preventative office visits did I have? So we have to enrich that data. And then we obviously, the last key there is displaying that in a meaningful manner that our audience can actually go do something with it. I talked briefly about the prediction side of it. Our view, when we look at data, we look at it really through three different lenses. The first is understanding what the risk of that population is at a group level, at a cohort level. Think of looking at all of your diabetics and what is their risk. We use some proprietary and commercial risk algorithms. Then we generate a prospective risk score that looks at that individual based on their known conditions, their known pharmaceutical scripts, and generate a prospective risk score that looks at where do we believe Joe Bush, based on his age, demographics, prior utilization, and claim experience, where do we think Joe Bush is going to be in the next, so that we can actually go derive recommendations to the plan sponsor. And then from a financial standpoint, we'll generate a third set of risk scores that look at the actuarial risk factors. So it kind of skips that future 6-month window to kind of eliminate the acute based events that may be occurring, to really focus on where do we think this individual or this cohort of individuals is going to be in the next 18 months. That becomes very important for underwriters that are trying to assess the financial risk of a plan and build plan design and plan rates around. And then really I'll kind of end with this slide and then open it up to questions, John. Our newest endeavor is really focused on what can we go do when we don't have access or our clients don't have access to data on their own specific plan. Either they're a fully insured group and the carrier is not willing to share that specific data. And there's 35, 40 million individuals that get employer plan, have fully insured plans. And then the other is they may be too small of an organization or don't have a lot of history to be able to identify what their risk is. We have created some partnerships and then associated technology that allows us to tap into aggregated data on a majority of the US population that is fed in by majority of the carriers across the country, the pharmacy chains. So they're the Walgreens, the CVS's, the Walmarts of the world, as well as the top 3 lab companies that contribute data de-identified into large data stores that we can then tap into, match it up with a known census file on a group, and then present a risk assessment for that population looking at a 60-month window. So looking over the last 5 years for this group and those individuals matched, where do we expect them to be at based on their known claim and medical claim experience, as well as a predicted set of expenses, so that a plan can start evaluating the appropriate plan design and the appropriate funding level. So this is a product we branded it called Census IQ, is really built to help those employers that don't have access to their data derive and build programs that can support the cost containment side. And then the second is to support our broker and consultant community as they are going out to market, trying to win new business. How can they identify what those risks are for that target employer client and come back with some unique proposals that, again, will also rein in those costs. So I'll come in for a landing there. That's a little bit about what we do at NAV. John, I'll kind of open it up to questions.
Yeah, that's great, Joe. Thank you very much. The depth of that is just remarkable. I'm interested in a couple of things, and then I'll turn it over to others. And the first is, you said that Census.io is new.
Thank you.
I'm sorry. Is it in production yet with any clients?
It is in production. It is in production. Yep.
Okay, great. Where do you find that your clients are receiving the greatest benefit? Where are they kind of recognizing that the most?
In terms of looking at the data and then putting in place corrective actions?
Yes.
Yeah. The first arena is in the pharmacy side. So in looking at specific scripts, all the way down to the NDC or National Drug Code, and seeing what many of these specialty medications may be costing. When they get visibility to that, then working with third-party vendors out there that can go procure those drugs in alternative formats, alternative sources, and save anywhere from 20, 30, I've even seen upwards of 50% off of some of those specialty meds.
Wow. That's significant.
Yep.
Yes. Others from the team have questions. Just based on my bias, Joe, have you attracted other former Cerner associates to the team?
Not yet.
Okay.
Not yet.
Okay.
It is I think it's a matter of time as we are continuing to grow as an organization. Not yet.
Okay. Where do you, in terms of,
that would be.
Amy, you have
And you may have a question.
Amy, yep, sorry.
Amy, sorry.
Yeah, I mean, I have just been thinking about the data that this is so valuable for these for your people to be able to look at, and how is that being accepted as a driver for some of the, like, for example, pharmaceutical companies and some of the maybe hospitals or long-term care facilities that have specific requirements for some of these, some of the information you may be providing them. Have your clients had success in using this data to drive change for them to decrease their costs?
Yeah, great question there, Amy. So short answer is yes. And here's why. So I mentioned there's some of the new fiduciary requirements that have came out of Washington over the last several years that chief HR officers, CFOs of organizations that are responsible for monitoring and managing that plan now have not only the added incentive, when one could debate, they should have always had that incentive, but now they have the visibility to see where they are spending their dollars in their plan and on what, as well as, and I don't think I referenced this, but it was on one of the slides, is we also show benchmarking, because knowing what you're spending and where is helpful, but you always need to know what's maybe a average or maybe even a best in class rate. But those organizations are using that data to then go facilitate conversations, maybe with the largest provider that is treating their employees and their dependents, or the PBM to look at alternative funding sources for specialty medications. Maybe they can source drugs internationally from Canada. They're using that information, and it's being received very well. And the primary reason it's being received well is that employer has all the leverage in the world. They are the client, and sometimes we have to help remind the employer group or the consultants that there are many different options across the market today of where you can receive or who can process your claims. If you don't like your TPA, go find another one. There's many out there. If you don't like this provider or that PBM, look at others or start creating direct contracts. Those are some of the areas that we're seeing the fastest movement.
Thank you. I appreciate that.
Sure.
Other questions from the team? Go ahead,
Yeah,
Scott.
sure. Hey, Joe, quick question as you think about maybe a couple things. One with the TPA channel is outside the TPAs provide further guidance to their clients on maybe different point solutions that they want to bring to the table. You have a high diabetic population, so we go some point solutions in that space bring to the client as well. Is that one of the main?
Yeah, from a standpoint, that is one of TPA, and I'm meeting with my employer client once a month, once a quarter. That employer client is consistently asking them, okay, I see what I spent and where I'm going. What can I go do about it? And so they're asking those questions, and that's why the analytics is so important, so that you can show, hey, if you were to introduce, to your example, a diabetic program, here's the scale and the potential impact. I will say that the second reason value proposition for that particular market, the TPA, is the automation and creating efficiencies. Many TPAs that we receive data from literally are still operating on green screens. They're not sophisticated. They haven't made large investments, but yet their markets that they serve, employers are asking for more data, more reporting. They're not equipped to go build it themselves. And so we can support and supplant that and create automation, create efficiencies, so a TPA doesn't have to have an army of data analysts per se.
And then the second question I had more on the direct to employer offerings, and as you think about the kind of growth of captives as a whole for the small to medium employer size population, less than 500, particularly those that are stereotypical here, but maybe a more white collar workforce that are getting community rated just because of their lack of size and just the arbitrage and savings they can get by going from a fully insured product to self-insured via a captive. Is that something, as you guys are looking and targeting employers, that you're looking at it from that lens and angle to show like, hey, you're paying, to your point, $25,000 a year gross cost per family, but your discrete population is 20% less because of your demographics. You're going to benefit by shifting over to a captive or level funded type plan.
That's right. Yeah. So we lump captives into that same TPA segment. And in fact, we actually have one of the faster growing captives in the country, which is headquartered here in Kansas City, called True Captive, that every plan that they support is inside of NavMD. And they have it as a captive, for those of you not overly familiar with their business model. They have a high incentive to manage those costs. And so having the data and the insights to see where those costs are and know what can be done is crucially important for them.
That's great, Joe. Thank you very much. We
Yeah.
really appreciate you taking the time to be with us today.
Thank you for the opportunity.
It's exciting to see this stuff kind of homegrown here.
Locally, that's right.
Yeah, we really like that. Thank you so much. And look, I hope that others may, if they're interested, message you during the rest of our time here to create some links. Since we started, we've had a few more people join. I'd like to welcome them to introduce themselves. Sorry to put you on the spot, but Haley, can you say hi?
Haley Bell. I'm at the University of Kansas Medical Center with the Telehealth Rocks team, as well as the Heartland Telehealth Resource Center.
Great, thank you. JD, Dr. Tyler.
Good morning. Sorry for being late there. I'm JD Tyler, MedPeds physician and owner and founder and CEO of Just Ask Evie. We do real-time virtual elbow support and training for clinicians using the electronic medical record.
Great, thank you. Mike Mitchell. Mike, you with us? Mike is with FoodSmart and still based here in Kansas City. Miguel. Miguel? There you are.
Hey, sorry about that.
Okay.
Yeah, no, I just joined from Overland Park. Mike Svetlik, Michael Brennan Media is my media company and specialize in HIPAA compliant short form videos.
Okay, great. Thanks so
Thanks.
much. All right. It appears that our second presenter, Kendra Wyatt, has not been able to join us, but I hope you don't mind. I will try to speak in her place because I've had the honor of working with her on this very significant project for this Kansas City region. And that is has to do with the ability to create a standard data set, particularly for maternal and infant health. I will share some of her slides with the team here. And just a second. And there we go. The first is really to kind of set the tone with respect to what the need is. And basically, and this presentation is one that she gave to a health IT standardization body in February of this year. But she was making the case, of course, that maternal health is just terribly significant within our circumstances. And that unfortunately, health information technology has really not kept up. And there needs to be much more to help address the particular need in maternal and infant health. She set up various different things that she wanted to look at. What we'll be speaking about today particularly is this second bullet from ASTP, which is the Assistant Secretary for Technology Policy, which is essentially the mature name of what used to be known as the Office of the National Coordinator for Health IT, which is a major body within Health and Human Services. And they are looking at standards, particularly set out for areas like cancer, also maternity. This item 2B is the data standard that they're setting out to unify, and which we would be hosting a summit here in Kansas City to help address. Here are some of the kind of statistics that we see within the domain. There are situations where we know, for instance, that there are great disparities in maternal health, particularly pregnancy-related deaths, where in particular, African American women die at a rate that is twice that of white women in the United States. And as you may be aware, the United States is lagging the rest of the world significantly with respect to maternal health. I believe that of the rich countries, the United States has a 36% higher death rate, maternal death rate, than the next nearest country. The specific topic that we'll be looking at is to work with the Assistant Secretary of Technology Policy and HHS to drill down on their specific U.S. Core Data for Interoperability, or USCDI plus maternal health, which means that is a specific area that they have called out for looking at the data. And what's interesting about this initiative is that we have developed really quite a close relationship with ASTP as a result of the way that this Kansas City community hangs together. And that is, we were originally introduced to ASTP through Digital Health KC and Dick Flanagan, who was able to bring one of their officers here for presentations. And based on connecting with him and then referring Kendra Wyatt to them, they actually invited Kendra to think about hosting this summit. And one of the nice things about this is it does have precedent. And that is last year in May, the ASTP held a summit in Nashville to look specifically at cancer data. And that summit was tremendously effective. They really did start to arrive at what the common data set should be for cancer. And by the end of the year, all of the electronic health record providers, or at least the major electronic health providers, health record providers, had accepted that standard. And that is an absolutely remarkable outcome. The EHR vendors rarely agree on anything. So this was very significant. It's a great precedent for what we might do here in Kansas City. We have tremendous amount of resources available to us from subject matter experts, some of them here on the call with us, and many others in the field who would be very amenable and very valuable to be making contributions to a summit. We also think we can count on tremendous support from civic organizations and others to make this a significant event, which brings tremendous focus on Kansas City for its contributions in this field. As you might guess from the poor level of data consistency, quality, comprehensiveness that's experienced in maternal health, that it's very difficult for healthcare providers as well as community-based organizations to be able to plan for outstanding situations in their communities. Most of the health data in maternal health that people access is often 3 years or more old. And it's very difficult under those circumstances and very inconsistent. And it's difficult under those circumstances for anybody to create things like meaningful interventions to address what really is a crisis. As I said, we are far behind the rest of the rich world in maternal health, and it really does not shine well on us. So this would be kind of the key focus that we'd want to see within the area and be able to bring new standards. We also would like to make sure that we do include the social drivers of health within the data set. Within the USCDI scheme, social drivers of health are not their own data category. Because they're so cross-cutting, they are found across all the disciplines, although their USCDI does have a specific SDOH work group to assist with this. So we would expect those folks to be involved and possibly a number, just as we would be inviting EHR vendors, we would likewise likely be inviting those who have resource and referral systems and things like that, several of which are actually based here in Kansas City. So they become community members and subject matter experts that we can bring to the table in hosting this summit. Work has already started. We have several national contacts already working with us to help develop this. We also have interest from funders already who think this is a great idea and would like to be behind it. And we've gotten to the point of at least having sort of a straw person agenda for the meeting. And before we end here today, I will also share with you a link to the guidebook for the Cancer Summit, so you can get an idea kind of what is likely to go on at this sort of summit. Though we would like to expand it significantly. The Nashville Cancer Summit did not have the vendors as part of it, and they also did not leverage as much of the strength of the local community as we would like to do. We would like this to be a significant showcase of the expertise that this region has, both in maternal health and in digital health. And so we're looking to all the institutions in the area to be significant participants in this. I've already put together a potential partners list, and it goes well over 100. There are just so many entities here in Kansas City that have an interest in this field, and we'd like to make sure that everybody ultimately has a voice in what goes on. I think I will leave it at that for the moment and invite any questions.
John, I think I can't speak specifically to Kansas and Missouri, but across the board, I think there's been some broader incentives or pushes by Medicaid managed care organizations to create bundles or at least some enhanced focus on this area in particular.
Yeah.
Do we think that, I guess, how does this kind of tie into maybe the data sources that they're using currently versus where they still have a lot of gaps and be able to monitor and, one, stratify populations, and then two, measure adherence to, standard kind of maternity protocols?
I'm sorry, I may not have picked up on that well, Scott.
Yeah, just trying with the kind of the goal of this forum in particular, relative to maybe what managed care companies are using currently for managing maternity care in areas where they're more heavily incentive.
Right.
What are kind of the biggest gaps there, maybe from what the commercial plans are using now versus what community health systems would find more beneficial?
Right. One of the challenges is the consistency of the data and the ability to share it between institutions. So particularly for a managed care situation, and maybe we could also have Lucia, who's on the call with us, speak to this. They have just a disparity of feeds that they get. It's not always consistent. And they find that there are often still faxing, that faxing is still a huge factor in this area. And it drives, we have a number of our health department colleagues on with us. It drives organizations like health departments nuts that they're still dealing with these tremendous amount of faxes. So the idea of making it common, consistent, and universal, we're still a long way from doing that. And this summit is kind of viewed as being a nexus for that discussion. Does that answer, Scott?
Yeah.
Thanks. Julie.
The panting, if you pick up any of that at the tail of my run, and maybe piggyback off of that question, but at the state level, a lot of states are not eager to hand over data. Researchers thinking might be identifiable, especially states like Kansas and Missouri, big large rural populations where you might be able to conceivably identify somebody based on the zip code or county And I'm wondering if there were any lessons learned from the Cancer Summit last year. Maybe this is too weeds on that, but if those cancer standards, was there anything about that? I imagine the same kind of things apply to certain kind of rare cancers in rural areas.
We certainly want to bring in the rural conversation. There's no question about that. Um, I'm probably not the best person to speak to the challenges there. I apologize, Julie, but the goal is that this would be ultimately universal and that it would be taking on, particularly since we would be hosting here in Kansas City, that we would particularly take on the rural perspective. Um, I'm hoping that kind of addresses your point. It was a little difficult to hear you over the current connection.
That's helpful. Thanks. Yeah, it's windy, but the rural population we have additional challenges, access for prenatal care in terms of getting to hospital on time,
Yes.
substance misuse issues. So I think that's really important. Thanks.
Yes. And that, of course, alludes to the social drivers of health and our desire to bring that in there. And travel distances certainly are a key issue. In fact, KC Digital Drive has proposed some work with the what is community paramedicine initiatives going on and growing in Kansas for more outreach to people in both prenatal and postpartum circumstances in rural Kansas in particular. Other questions? Well, I can certainly say that we are tremendously grateful for everyone being here today. In fact, for this particular initiative, we'll be looking for the support of everybody. It's going to be a very vital thing. There is, as you might recognize, a significant challenge right now in that this Assistant Secretary of Technology Policy Office was elevated to that level under the previous presidential administration. It still is holding that role. Currently, there is an acting and very experienced director, but the current administration has not yet named who the permanent director would be. And so there may be, changes in priorities and those kinds of things ahead of us. But the dynamism of what we're seeing is that several of the people who are involved at the national level would like to see this go ahead in any event, to go ahead and set the standard and take it to the national level, even if support from ASTP is not direct. So we will be engaging this further and look forward to what we will convene here in the Kansas City area. So, Josh, you had a point. Would you like to speak?
Yeah, I think there's the sand is still moving, right, on these topics. So I really love the collaboration we have here as we look towards the future. Super excited about the potential for the event that was just discussed being hosted and having impact there in Kansas City. Specifically, though, when it comes to, and I will probably butcher his last name, the nomination of Michael Kratsios for OSTP. I do see, this forward-looking vision around data that I'm hopeful will filter down to all of us on the health side. So again, choosing the sunny side of life with that comment, but once we move past, the Doge Lord activity that's kind of impacting a lot of us, especially, regardless of where you interact with federal, that's going to impact. And then the leaked April 16th memo, OMB memo tied to, budget reconciliation that has healthcare, specifically public health, scrambling quite a bit right now to understand what could be the impacts for us as we look toward September. But beyond that, hopeful around data that in the fall or winter, we would see a new federal initiative that centers health data and wellness of Americans. But also, I think it's safe to see in some of the nominees over at CMS, HHS, et cetera, there is a real emphasis in their past around maternal child health. So again, that's encouraging at this point for our leadership team at Health and Senior Services.
Great, thank you. Yeah, it's great to have you involved with us, Josh. We really appreciate it. Any other questions? I think Josh's point was very significant. Okay, with that, I guess we will adjourn. And I thank you again all for showing up and being able to listen to this. And my promise to get back to you on support for the summit. We really look to it being a community-wide effort, a region-wide effort to make something big happen. So thanks so much, and looking forward to see you all again in May. Bye now.
Thanks, John.
Hey, everyone.